Hello, everyone. Sorry, having audio difficulties. All good, Shalini? Yeah.
Can you just check that there's no feedback?
Okay, so we're just getting the audio set up. We've changed rooms due to the issues we had last time. So could you just get a thumbs up from someone who's attending that the audio is coming through clear and there's no reverb? All good, perfect.
It's all
Thank
good.
you, everyone. All right, so welcome to the Implementation Science Interest Group. Today we have a presentation from Dr. Bianca Forrester, the title of which is Moving from Crisis Response to a Learning Health System, Implementation Experiences from an Australian Regional Primary Care Network. So Dr. Bianca Forrester is a GP and academic, and she specialises in adolescent health and wellbeing, workforce development, and change facilitation. As a clinician, Bianca delivers early intervention and enhanced primary care to young people from disadvantaged backgrounds through a place-based approach to enhance primary care in school settings. And as a workforce development consultant, Bianca's work focuses on understanding the grounded experiences of service providers in implementing policy advice and best practice approaches to care in local and regional settings. She has extensive experience in workshop facilitation and stakeholder engagement, having facilitated hundreds of systems change and solutions-focused workshops in response to the pandemic. Dr. Forrester is currently designing a strategic and operational model of a learning health system for the Western Victoria Primary Health Network, on which she will be presenting in this Implementation Science Interest Group meeting. So before we get started, I'd just like to give an acknowledgement of country. I acknowledge the traditional custodians of Macquarie University land, the Wadawurrung clan of the Darug Nation, whose cultures and customs have nurtured and continue to nurture this land since the Dreamtime. We pay our respects to elders past, present, and future. And so now I will hand over to Bianca to start.
Okay, thanks, Georgia and Shalini. Thanks for having me here. Nice to be with you all. I'm going to start by sharing my screen, and while I'm getting that loaded up, I'd like to pay respects to the Wadawurrung clan of the Darug Nation. It's nice to be up here on the Darug Nation. I've come from Wadawurrung country, where I live and work, and this bridge is on Bunurong country. So this is the lands of my ancestors. This bridge was built by one of my great-great-great-great-grandfathers and is a keystone bridge. So there's no mortar in this bridge. It's all held together by that keystone. Each block is carved to create that balance that holds that bridge. And it's a symbol that I guess or a metaphor that I'm thinking about as I begin my PhD, and a lot of the spirit of the work that I'm doing in facilitating communities of practice is around bridge building between the West Vic PHN, Macquarie University, where I've just started my PhD, and some of the services through which I work in regional Victoria. I'm also a Melbourne Uni senior lecturer, so I guess a bridge between Macquarie and Melbourne Uni too. So this presentation is titled Moving from Crisis Response to a Learning Health System, Experiences from an Australian Regional Primary Care Network. And I'm going to start by telling the story of how we really responded initially to a crisis through the pandemic and have reflected upon what we've done and tried to systematise our approach, as Georgia describes, to create a strategic operational model for a primary health network. In responding to that theoretical conceptual framework of a learning health system. So this is my region at a glance. It's Geelong is a city 75 kilometres from Melbourne, and Ballarat 100 kilometres from Melbourne. So we are regional, and we span a region that goes all the way out along the Great South Coast, the Great Ocean Road, out to Warrnambool and Portland, and that South Australian border. It's very vast, as you can see. It's 80,000 kilometres distance, serving a population of just under 750,000, with 809 full-time GPs. We've got a diversity of services across the state and federal funding mix, from general practice, public hospitals, community health services, and residential aged care facilities that are variably state or Commonwealth funded. So over the course of the pandemic, this was a challenge to kind of really think about coverage and access of our technologies in response to COVID. And going forward, I think there's a real sense that we can do some great things in terms of strengthening health outcomes, but also equity for regional Victoria. Now, as I'm thinking about this in the first few months of my PhD, I thought I'd start with three things that really bug me. What really bugs me is patients falling through cracks in a fragmented system and really watching them fall in. I think as GPs, we are at this vantage point where we can see all the problems that are going to happen along the care continuum, but we feel sometimes very powerless that we can do anything about it. So that's one of the first problems that I'm trying to respond to with this strategy. I think research being done to us without meaningful co-design, I think, is a real problem for us as frontline workers. So how do we really think about the reciprocity when it comes to research, or how do we capture those opportunities where we're working with clinicians to both educate and give something to them, but also capture qualitative insights while we're all there? So that's part of, you'll see that theme coming through with some of my community of practice work. And then I think when it comes to clinical governance and policy decisions made about primary care, one thing that really, I think I always was aware of, but really became quite stark through the pandemic, is that often these decisions are being made and we're not actually in the room. So how do we actually bring frontline workers or clinicians, GPs, nurses, my intervention has really focused on GPs and nurses and practice managers, but increasingly allied health clinicians are coming to our community of practice. How can we ensure that decision making is done with them and that they're in the room? So where did we come from? And why a learning health system? So when we first started, and it was in March 2020 that we started our community of practice in response to COVID, I think probably about the week where the pandemic was declared, we worked in a kind of, we basically clocked that chaos was kind of ensuing, and our work kind of was to move from disorder into chaos, if you like, and try to respond iteratively, proactively, week to week, day to day, just piecing things together and getting stuff out there. And we really had to kind of learn to systematize our approach, and I'd reflect upon the last few years. We've been transitioning into this model. What you'll see in the centre is a really brief, and I'll explain it in a bit more depth in a moment, a really schematic model of a learning health system. So starting with a problem of interest and thinking about how do you build data, knowledge and practice change and respond. So in my mind, that model helps us move from chaos to the complex. And then going forward into the future, how do we take an operational model and use this operational model to really be able to respond to complexity as business as usual, which is, I think, the environment we increasingly recognise that we're in health. And so how do we use this model? If we can get this model right, if we can implement this model and say that this model's right, how do we apply it to big issues such as primary care reform, complex care and reorienting health services, and how can this model actually help us be ready for the next crisis? So where did we come from and to? That's okay, that'll open up. Oh, you like that? So we started with this sense of chaos. We realized that we were coming back week to week, and we used a learning cycle. So we wanted to create a learning loop week to week. It was an iterative loop, and we wanted to routinize this loop and garner organizational support for our learning loop. So we built a community of practice. It was our WVPHN COVID-19 pandemic response ECHO network. It's a bit of a mouthful, but where that all comes from is it's Project ECHO platform. I'll tell you about that in a moment. And we were an ECHO network, or a learning network, a community of practice of sorts, to put policy and evidence into practice across our region. We came together as diverse stakeholders, GPs, specialists and primary care teams, health service and public health unit experts and specialists, allied health clinicians, community health, RACs, nursing, maternal child health, disability support. We'd have different features or population priorities that we'd focus on throughout the series, and people came and went if they had a specialist interest, with primary care, nursing and practice management being with us throughout the whole 3-year series. We ran over 100 learning conversations over 3 years. Generally, around 50 people on average attended these sessions, which equates to about 5,000 systems thinking hours of conversation run week to week. These sessions were highly rated, with participants describing them as very relevant to practice, that they would generally learn something they would put into practice that day, and that they were met their learning outcomes in the majority of time. They told us that they talked to other primary care providers after session. They generally in one evaluation we did, they said they generally would talk to someone after ECHO sessions and communicate what they'd learned, and that the theory is that this then benefits consumers through change to health behaviours. ECHO participants, our core community of practice groups, were regarded by their peers as knowledgeable. So, they'd tell us things like people would come up to us after an ECHO and say, what did they do at ECHO? We'll just implement that. So they were regarded as people who could advise on the changes required in the pandemic. One of our GP specialists that I've described as the lead editor for the COVID health pathways for Victoria and Tasmania. And she was a SME for our series, but she would also take the conversations and code the nuance of putting policy into practice in a regional setting. She would code that into the health pathways that reached across Victoria and Tasmania. And what was interesting to her was, of course, I'm not sure if any of you are familiar with health pathways, but they are our primary health network care pathways. So the idea is that these are clinical guidelines translated by GPs for GPs. And so they'll translate the nuance of the clinical guideline into a way that GPs understand or work through these guidelines. And then they'll also detail care pathways. So then we'll seek to regionalise the care, so that if you're in any area, if you're in Horsham or whether you're in Warrnambool, if you were trying to find a specialist to do a particular thing, that would be coded into your pathway. And so we did a lot of work offline coding care pathways. And so I reflect upon, as we become a learning health system, how we're going to kind of evaluate what we do. So we do series evaluations, session evaluations, and of course we have web traffic data to measure to see what impact we're making. Vaccination rates are accessible on Federal Department of Health data, and we believe we were leading through 2021 uptake for vaccination. We were told by our health services that our region was one of the only regions that wasn't inundated with inappropriate referrals, and that they felt this was due to these conversations at ECHO and some of the communication channels that we developed between our specialist services and GPs. That meant that a lot of our queries related to specialist immunisations were resolved without the need for referral. We know that we had some of the highest antiviral prescribing rates in the state based on linked PBS and state COVID notification data, and that there was a period in 2022 where hospitalisations were significantly lower in our region than in other areas of the state, and this was based on health services data. So we feel that we were pretty good at knowledge. We reckon we were great at change, but we do have big data problems in terms of sometimes accessing this data. So what I realised when we got to the end of this 3-year period of learning conversations, that in order to be able to measure and describe our intervention in the context of our impact would be challenging, because a lot of the data that we need to access to tell the story of primary care sits outside of primary care. And that's a challenge to be summited. I'm going to use summited. I'm going to use that metaphor. I'm changing metaphors from bridges to summits. So now moving towards a learning health system. So those of you who aren't familiar with learning health systems, it's where this is based on the IOM, the Institute of Medicine, the National Academy of Medicine in the US. First described this model in 2007, where we start with a problem of interest and gather the best available data, synthesize the best available evidence to generate new knowledge, and then conduct a gap analysis of sorts to see what needed to change. I'm going to overlay it with the Monash model with a bit of a tweak that I've popped in there, where you actually start with gathering data and insights. You bring in stakeholder insights, so knowledge, not just research and evidence knowledge, but the insights or the evidence, qualitative insights from stakeholders to build new knowledge, to think about change. And I've put transformation under there, because the reflection of a learning health system is that every time you go around the cycle, the whole system should learn so that they're better at doing the next cycle. And that's something that we're certainly trying to adopt in our own organisation. And the key questions for us really as an organisation as we move towards becoming a learning health system is thinking about, when we look at these cycles and we try to measure our impact, is to think about this synthesis activity and really reflect upon what needs to change and how are we going to change things and how will we measure what matters. So that's a reflection on actually, I guess, that understanding that we haven't historically necessarily measured what matters, but what matters is really what matters to consumers, and to really bring that voice or that need to light, that we are in health about serving consumers and making sure we're capturing what matters to them. And I'm going to put forward that I think it's also what matters to providers. So And you'll see as I move further down the slides where that aligns with the quintuple aim and value-based medicine, value-based healthcare. So that's the basics of the learning loop, but it didn't start like that. We started in a very messy way. Back then, it was create a learning loop to mobilize knowledge, find missing knowledge, transfer it to where it's needed, and organize it for future use. And this is a tweak that I think resonated as I was starting to think about what we were doing back in 2020, that we were as far as possible trying to avoid this happening and make sure that we were as a region all on the same page and we were all traveling towards from data to information to knowledge to insight to wisdom and really using our health resources in the most efficient and impactful way. We recently submitted a paper to the Learning Health System Journal, and the first reflection that I had in terms of what were we actually doing was I was thinking about this whole process as a theory of change, and this theory of change is based on the Cotter's 8-step change model, which is from the business world, but also adapted from Peter Stroh's systems thinking for social change. And we've kind of condensed the 8 steps down into 4. And the first step really is then you need to create a sense of urgency. Well, we didn't need to create that. The pandemic did that for us. So we could skip forward to the next piece. It wasn't hard for me to call upon people and say, come and be part of these sessions. So forming a powerful coalition, a network for effective knowledge mobilisation was step 1. And bringing people and culture, creating a culture of learning and inquiry was really the foundation of change for us. Phase 2 is that we had to create a vision for change and communicate that vision. We actively facilitated an iterative approach to change management using systems thinking practices. In phase 3, we needed to then look at, I guess, really lean more into implementation science as I'm now thinking about it. But really at the time it was thinking about where are the barriers and enablers here and how can we create some quick wins? How can we see something that could be really easy to change and just point at that and get someone to go and change that so that it made life easier for clinicians and for patients. And that ended up looking like developing supportive organisational infrastructure and creating care pathways for consumers. And then finally, as we go through this reflection stage, really, I think that's part of any kind of systems transformation. You end up going down to this reflection stage where you have to review everything and then consolidate it, is build upon the change, make it stick. So how do we establish a durable learning health system model? How can we review progress, refine the model, and apply to other content areas? So that was our theory of change, and it all pretty much came from me because this is the book that I was reading during the bushfires, how to enable groups, communities and societies to do things they've never done before. So I think I was reading that because I was worried about climate change and the bushfires were happening and I was keen to really do something impactful. And then when COVID hit, I kind of felt a little bit, I'm going to say confident. I kind of felt like I kind of had a few things like one of the I'm just trying to remember his name now, head of the UN, I think, said, just don't let the perfect get in the way of the good, roll your sleeves up and just do something. And so I think that was a very enabling environment to step into. So I'm going to work through these stages in a way and just share with you a bit about what we did. And you'll see kind of how we've arrived at this learning health system reflection. So basically the first part, that's supporting a powerful coalition, building a powerful coalition, a network for effective knowledge mobilisation. We basically wanted to support clinicians to change. So we needed to develop the organisational infrastructure, this community of practice that I've described, and really to change looked like diffusion of innovation, I guess, in implementation science speak. It was kind of like we created this event each week and people then would just go do. And we did lean into that, as I described, some dissemination. I'll show you that in a moment. But what we recognised was that, everyone was focused on the pandemic at the time and everyone just wanted to kind of come, get that once. They talked about Echo as being a one-stop shop where they'd get all the information they needed for the week to just get on and do, and they just get on and do. And so we did recognise that diffusion of innovation was taking place. So Project ECHO stands for Extension of Community Health Outcomes. It's a platform, I guess. I would say it's a platform for community of practice. So it comes with an immersion training. Luckily, I just done the immersion training, I think on the 22nd of February. So I was ready to set up. They say it takes 6 months to set up an ECHO. We had our ECHO up in 3 weeks. But we'd all done the immersion training. I'd done it with the Uni of Melbourne. I knew I cottoned on to the fact that West Vic had done it as well. And so we could kind of have that conversation. You can echo, I can echo, let's echo. You know what this role is, I know what that role is. And we could just get straight to everything was there for implementation. And there's really strict model fidelity involved. And so we could just kind of get it up and going. So all the implementation pieces were there. The idea with ECHO is it's about amplifying best practice through case-based learning and this kind of onus to make sure you're recording and gathering data for everything that you do so that you can evaluate your community of practice model. So I think it's a nice rigorous model to base a community of practice. In fact, you know, I think it's so good. I wouldn't look further at anything else. I think this is working for us. The ethos is all teach, all learn. So it's a flattened hierarchy. The idea being, I think we have a funny system in Australia where it is like there's a hierarchy of specialists and GPs, where GPs actually see themselves as specialists. And I think ECHO writes that a little. It talks about experts in context, working with experts in content. So the content experts bring us our didactic, and then the context experts, the GPs, solve the problems in practice. And GPs would tell me through ECHO, they loved this. They loved that idea that their contextual knowledge was valued as highly as content expertise, because it's what made the difference to implementing this into practice or translating into practice. The other piece of ECHO, I think that's important, is it's about moving knowledge, not people. So this resonated with us in regional areas, that we're not trying to get people to come to the, you know, ivory towers of excellence in metropolitan Melbourne. We're trying to ensure that that this knowledge is out in regional communities. And there is RCTs done for the ECHO model, and they're based, I think, on hepatitis C in India, where GPs in rural India were given a dose of 6 months of ECHO for hepatitis C. And what they found was that over a period, I can't remember the period of time, but they basically had the reason they did it, the reason they implemented ECHO was that there was a good 2-year wait for people with hepatitis C to see the specialists, and that meant they were getting liver failure and hepatocellular carcinomas, and they wanted to make sure that a lot of that work was done in primary care. And so they found that after a period of time, care was as good done by GPs in the community than it was in the specialist centres, and they cut their waiting times down to about 2 weeks. So that was the platform we used. What we did with that platform was we tried to create a vision for change and communicate the vision each week, actively facilitate an iterative approach to change management. So myself and Kate Graham, the colleague who runs Health Pathways, with our colleagues from various areas, whether it was in the early stages, it was with a colleague, Deb Freeman, who eventually went on and became a Deputy Chief Health Officer. And then later on, it was with the public health units. We would curate as much as we could, as much as we could grab hold of every national state policy relevant to us, national and state guidelines. I would interview people and find out what's happening, what are the problem spots right now, where are the pain points. I'd talk to GPs and say, what's frustrating you right now? Tell me all about it. And we would curate an agenda for the week. We would have an epidemiological announcement, and we'd talk about what the rates were doing, because we didn't have data transparency in the early days. So we'd only really hear it at ECHO. We'd hear about what was happening with cases, what the advice was in terms of PPE. We'd hear about guidelines and policies as they were unveiled. And then we'd decide what the didactic needed to be. So what did we need to learn about that week? And then I'd make sure that there was a case presentation brought by our GPs to work that information into practice. So as discussed, we had those experts in content, talking to experts in context, building new skills, attitudes, thinking about incentives to build new processes and behaviours in practice. And then we took the conversations and coded them back into Health Pathways and developed those refined those clinical guidances. So I might need to be a bit careful. It's probably not clinical guidelines as such. They're the evidence-based guidelines, but the Health Pathways are guidance. So it's taking those guidelines into translating by GPs for GPs and creating local pathways. We would use systems thinking practice. So we would, I think this is from the Australian Prevention Centre. I would try to touch upon these various different practices. And I think probably this happens in a very, I guess, intuitive way. I'd been trained in some systems thinking methodologies to help me work out how to do this, but this is what we were often looking for in each session. Of course, bringing in diverse perspectives, making sure that we had representation from consumers, clinicians, different types of clinicians. If we were working on nursing homes, we would bring a nursing home nurse in to talk to us. And we would, week to week, reflect upon what we were doing. We would think about, where am I an actor in the system? And we'd try to make sure that we weren't saying that someone else needed to do something. We always questioned, what was my role? What can I change in this? If there was something that was a problem that was outside of our role of action, who could we talk to about this problem to see change occur? And if we do one thing, what is the unintended consequence that we're going to come across? Like, if we built a model that looked at this, what was going to happen? If we sent everyone outside the clinic because of the risk of exposure in the clinic, then what was going to happen to people who couldn't sit in their car or couldn't drive or couldn't, were we going to miss chronic disease issues? So we were always looking for those unintended consequences. But it was nice, I think, when one of the regular participants came and said we'd learn strategies that we could apply to other situations. So the things that we were learning for COVID, they were applying to some of their other clinical practices. And I think we worked on our mental models and worked kind of to see the bigger picture. So what came out of these case discussions is that we weren't just kind of doing education about me with my patient, which often is that traditional medical education, that clinical learning and knowledge translation. We were thinking about me within my practice, and certainly COVID really made us as GPs do this, is how do we ensure the way that a patient flows through a practice and who sees that patient is going to prevent us from getting furloughed, as an example. We had to think about as a practice, not just as a independent contractor. And so we had to really build new models of care in primary care, and we had to think about quality improvement. It really forced this upon us. And then we definitely thought about we within the system, me, my patient, and how they're going to travel to these other parts, these other touch points. So it challenged us to think about integrated care models and new integrated care models. And I think through that 3 layers, is where we always worked, and we kind of tried to name where we were when we were thinking about these issues, so that we could bring in then the right person who could be, who, if we weren't actors in this part of the system, in the, say, that end-to-end communication, then we'd make sure the next week we'd bring someone in who could respond or resolve that issue. So we always try to think about, what's my role? What are those relationships and interdependencies? And how do we bring about that self and context awareness? And I think that did really help a lot of clinicians to kind of, again, just get on with, I think a lot of people worry about what's out there in the system and they feel very powerless to change it. And by bringing the right people in who could affect other elements of the system, and by facilitating the conversation to direct the questions to the right member, I think really resolved a lot of our issues in practice. And I think that the transition in the training was about thinking not just about, often people talk about GP education as about building capacity, but I think when we're thinking about it in this way, it's about building capability. So building this capability, learning skills that they could apply to other things. Now, so as we matured, we needed to really develop this supportive organisational infrastructure, as I described. So we've got the kind of the knowledge management cycle on the side, but we needed to build this change management infrastructure to support that cycle. And it was very iterative. We had all of this in the Western Victorian Primary Health Network. We had all these, players. So we had a communications team, and we had clinical advisors and executive team members and commissioning teams and workforce development. We had all of this kind of under the hood of our primary health network. But the question is, how were they going to wrap around the lessons of this knowledge management group, this cycle? Administrators would come. In fact, it was always great. The CEO would generally turn up and be there, either driving, out into the country and listening to the conversations, and practice facilitators would join so that they could then communicate what happened at ECHO to whatever practice they were visiting that day. And so it did seem to just evolve, to be honest, which was great. And so we actually, I'm going to skip forward and skip back, actually. So ECHO became the buzz, and our organisation was a hive of collective action. Through listening to these conversations, we not only through the community of practice were able to build relationships, share and create new knowledge, enable system awareness, develop new ways of working, and amplify messages. We were able to get the organisation to actually build that supportive infrastructure around these things. So we're able to develop these networks, these educational networks, and improve by adapting guidelines. We were able to do some commissioning by leaning into the gaps that we were hearing were occurring at ECHO. We were able to embed new processes through the element of our practice facilitation team and use our comms team to increase our reach. How are we going for time? I better just quickly. Am I right? Okay. Oh, I've got to put the timer on. Am I half hour through? Okay. So we developed care practice models and pathways. What the questions were in the early days was really like every case that came forward, essentially, the key question that the clinician had was, where am I seeing this patient and what am I wearing? They didn't need to learn anything new medically. They really needed that situational awareness of what PPE am I wearing and where am I going to see the person? And what we would hear in the conversations when we were asking this, doing this facilitated technique was, people were asking, well, do you have a room out the side, or do you have a marquee, or do you have a car clinic, or is it a tent clinic, or do you have separate access way? So what we could hear through these conversations were all the dependencies. And I think in that systems thinking practice, it's thinking about those, that contextual dependency that clinicians need to think about to design models. And then we developed infection control practices and workflow in primary care. We normalized telehealth and built telehealth models and reflected upon those models. We built vaccine rollout models for flu, which we later revisited the year later and looked at COVID vaccine rollout models. And then, of course, we've no sooner just gotten everyone out of the clinic and into marquees and cars and tents and things that we needed to then think about how we get them back in the clinic when they needed acute respiratory infection assessment models in winter. So one of the unintended consequences of keeping people on telehealth was then they weren't being seen for their acute infection. So we had to create new models again. And that's what we did. So Echo did, how far did we reach? We ran 83 unique sessions with lots of attendees, on average 50 a session, with 38 who I'd consider were core GPs. We spanned 114 clinics. I can't remember how many clinics I said we had. Probably, I think that we had 200 clinics, so we reached over half of our clinics and other organisations. And we had these big amplification sessions, these town halls, where we'd then communicate what the working group had worked out to a broader group. And usually about 150 or 180 people came to them. We also sent everything out as podcasts. Of course, we developed the health pathways, and we developed a lot of web pages that people could click on to access information resources. And the sessions were highly rated, as I described. I might skip over this, but I think this was probably a reflection on all the problems really that we faced, and I'll just let you read some of them. And I'm sure those of you who worked in primary care will remember this. This is very much how probably 2021 and 2022 felt. And I think maybe the key one for me was it's not always about knowledge. I mean, we got to this place where we were trying to implement policy, and this was kind of an insider scoop, was the advice is clear, it's just not workable. And this was really hard. And sometimes I think this is where decision-making, we did need to be part of decision-making. Our COVID antiviral sprint was, kicked off in 2022, and I had a feeling we were onto something by this point. This is a sample agenda of what we would do. We'd do a content push as our didactic that would teach the GPs about the things, and then the case discussion was how are we going to implement the thing. So whether someone was in Horsham, Portland, Warrnambool, Ballarat or Geelong, how were they going to help an 82-year-old access antiviral medication? And we would try and solve that problem in session. And so we did this co-designed series, and I wanted to start to look at, well, let's look across care continuums, or I call this the cascade of care. This was based on the STI, some work by the Kirby in the STI field, where you look at, people need to get through this whole cascade, really. It's, they have to have, you've got those who've got disease and no diagnosis, those who then have a diagnosis that we identify, then that identified person notifies or presents to a service, they've got to access the service, then they've got to be eligible and receive a script, then they've got to access the script and finish the script, and then they've got to come for follow-up. And there were all these steps along the way that we needed to kind of interrogate. And that's what we did across this sprint, is we interrogated every step along the way to see how we could tighten up that, both that patient journey and the clinical workflow, tighten together to ensure that no one fell through a crack. And so here, and I won't go into depth because in the interest of time, but here are the types of things that we were looking at each step along the way. And we were actually brokering access. We were recognising that GPs said if they knew which pharmacy had it, then they would be able to send someone straight to the pharmacy. So we built an interactive pharmacy map. We spoke to all the pharmacists in the region and at least made sure that one in each town purchased the $2,000 drug, had it on the shelf, and that all the other pharmacists knew they had it, because patients were very anxious in Horsham that, you know, there could be a delay and they needed to get this within days. So we did a lot of kind of offline work using our COVID commissioning dollars to just try and seal over these gaps. And we had the highest GP antiviral prescribing rates in Victoria. So this is from a paper that was released late last year that people living in the Bowen Southwest region were most likely to be prescribed oral antivirals for COVID-19 in Victoria, with most prescriptions by GPs. So, you know, I think for me, this felt like standing on the top of the mountain. We kind of had done this we'd done this complex intervention to try and really affect the uptake of technology and keep people out of hospital. And we'd done well. But then I guess we had to stop and think, right, we can't keep doing this at this rapid pace. And we have to think about how we're going to sustain this change, because it was pretty exhausting. And this is a quote from Kedamate, that it's time to sometimes move at a slower and more incremental pace when it comes to big systems change. And so we needed to build on this change and make it stick. And this is where that learning health system model came to me as a model that could be really could work for us. And that we could think about, these were the things that were really apparent that we needed to think about, that aligned value proposition. We had to align our value across primary care and specialist services. And we needed a resourced and supported process so that we could bring data, knowledge, stakeholder change and transformation to bear in line with the quintuple aim and value-based healthcare as our valued outcomes. So our mechanism is this change model, and our outcomes are the value-based care and quintuple aim. And so in writing up this experience report and preparing for this PhD, we dug into the literature on learning health systems and used this model by Menier et al., who in Canada, who describes a framework for value-creating learning health systems. So for us, the community of practice sitting at the centre were our ECHO and our learning labs, and we developed design labs. So I started to recognise that we did an informal debriefing process after every ECHO. How do we formalise this debriefing process, and what are we actually doing in this debriefing process? And I think what we were doing was designing systems and determining actions that needed to be taken by different players in the system. So we have dual communities of practice, if you like, the learning lab for clinicians and the design labs for health administrators and external partners, to make sense of what we hear in learning labs and then create change. We run through the learning loop as discussed. Our ecosystem of change is our whole region, but so we're thinking about the regional change towards the quintuple aim and value-based healthcare, which is depicted up the top. Of course, there's all this infrastructure that needs to be put into place, and they're described as pillars by Menier. And the key piece for me, I think, is this connected and aligned. How do we bring these pillars together through each learning loop? And that was really the focus of my work last year, was how do we connect all these people? How do we connect our data analysts with our clinicians? How do we connect health pathways with what people say in conversations? And how do we think about policies and practices to support this model towards the key challenges, as Menier describes, of knowledge management, change management, data management. And for us as an organisation, I think there's organisational change management that I'll add to Menier's model. And so our process model is, you know, this is the most simple model I can think of, is that we're going to start with that problem of interest. And for us as a PHN, thinking about what should we put the resources into, identify a problem that we want to run a sprint on, which is quite an intensive process. So we have this identification phase, we run our sprint phase, so these learning labs and design labs running alongside each other around a problem of interest. And then we have to think about, well, what needs to change in the system and how are we going to get that happening in practice? So that's that project realization, the specification phase, and then ideally our project streams go, which could then be evaluated. So this is the model to generate impact and be evaluated. And this is the model that I'll evaluate through the PhD. Thinking I'm probably going to skip a few slides now because in the interest of time, so I've got about 5 more minutes or 2 more minutes.
10. We can have 10 minutes.
10 more minutes?
Yeah.
Oh, okay. Well, if you'll indulge me, I'll lean into this rationale. So where are we up to now? So as I've mentioned, we've kind of put that line in the sand and said, okay, COVID, we probably finished our COVID activities in earnest late 2022. And in 2023, we needed to start our organisational approach. And so this work comes from Tom Foley and a group called the Learning Health System Project in the UK. And they say that there's 4 key questions to think about when designing a learning health system. What is our rationale for doing it? What technical building blocks will we need? And I think hopefully you'll hear that I think we've kind of established that as a group. We know why we're doing a learning health system model, and we've got a lot of the technical building blocks, but we do probably need to think about a gap analysis for ourselves in terms of our maturity. But the bit that I'm going to lean into now is that thinking about those sources of complexity that exist at the system and intervention level, and the strategic approaches to change we need to consider. I think this is where we're kind of leaning into now. And so for us, in terms of that, the strategic approaches to change and understanding complexity, and yeah, this slide's probably, I'm sorry, this is probably part of still me thinking. It's probably a little bit of a complex slide. But the thing that I've been thinking about is how do I get this organisation to support learning health systems going forward? We did it through COVID. We're kind of doing it now as a bit of an education series. But how do we really kind of make that meaningful organisational change? And so digging into the literature, it's very much about thinking about those change management facilitators, that supportive leadership and governance, making sure that everything that we're doing with this learning health system aligns with the PHN strategy, thinking about how do we garner those resources to make this part of business as usual. How do we get a team that's perhaps worked in a traditional project management way to start to adopt agile and lean project management? And how do we really support people to make that transition, those relationships, and formalise some of those relationships that we built through COVID now into kind of business as usual? So those relationships with our external stakeholders that perhaps need to be formalised. I think then in terms of what I'm trying to say in that top part is how do we use our organisational strategy to develop this model that's fit for purpose, that has a change management approach in industry that aligns with our state and federal, private and public kind of interests, and also is able to provide advice to policymakers. How can we make sure that this engine or this model, if you like, provides really policy-ready advice or policy-ready research, if that makes sense? And that's one I'll have to puzzle a bit more on. And so thinking about this is kind of really important, because when we look at, this is Trish Greenhalgh and crew's NASCAT, it's from it's their NASCAT tool. They look at complexity across 7 levels. And it comes from an article, I think, that talks about why implementation efforts fail. Many of you be familiar with it. But for me, I think this is, it's kind of an exciting and daunting thing that there's 7 ways in which this could all fail. And the bit that I'm going to be focusing on, I guess, with the PhD or the industry part of the PhD is how to get this healthcare organisation to participate in this work. And where I'm focusing, and that the regional learning health system my computer's trying to tell me something. This learning health system is a process to enable that continuous embedding and adaptation over time, which is why I think we really like this model. But really, when I think about where I'm working, it's thinking about the condition we select in that prioritisation process, the technologies that need to be implemented or might support our work. What's the value proposition for GPs and nurses coming? Why would they come to learn about this? Is this something that they're demanding? So it's that bottom up rather than top down value. And how are we going to reflect upon this knowledge with our adopter system, staff, patients and carers, in this broader context? And so that's kind of probably really where I'm putting my lens through this project, which is because we are working from that community of practice and culture change level. So after COVID, we've started to do all these things. So we put our learning and design labs across cancer screening, women's reproductive health. We're now looking at child health, and we've just finished an ADHD shared care sprint, and I'm planning at the moment for a sustainability sprint and a cardiovascular sprint probably in term 3. So we're trying to now flex this learning health system approach to other issues and other complex problems. And I'm going to skip through, but the thing as an example of connected and aligned, I wanted to make friends with the state government, and I knew that they just released a STI strategy. And so one of their pieces was around systems enablers. So these were some of the themes of their system enablers: the strengthening workforce capacity, fostering partnerships and collaboration, strengthening and supporting data and research, and looking at stigma, racism and discrimination. And I thought, right, great, I think we do that. Let's now take this strategy and show how we do it. And we tackled some key things in that strategy. And just to give you an idea about how this may perhaps aligns with research, is that the sprint involved about 14 key informant interviews. We had 5 focus groups or learning labs, and we had 4 focus groups or design labs. So, you know, going forward, there's just a heap of potential in terms of, you know, qualitative research that we could do in a sprint. And this is a 12-week sprint, so we're going quickly. And these are some of our outcomes. So for our cervical screening test, the sprint looked at, let's create a data QI project using Polar, where the GPs whip some data from Polar, and they develop a PDSA, and then they do a few cycles, and then they report upon it. And let's get that accredited under our CGP, and then let's make sure that's a measuring outcomes thing that they are going to be keen to do, and let's run a data club alongside it so they feel confident in doing that. So that was a bit exciting, and we actually got 2 or 3 practices that actually submitted up to our portal. So we created, if you like, a data QI change process, which a couple have successfully done, and there's been actually an evaluation of our rates over that time. So I'm quite keen to see how we did from a systems level. Early medical abortion, we wanted to say, okay, let's look at the data around access to early medical abortion, and we could see from that little tiny data visualization that we've got deserts out in regional Victoria, and we wanted to see if we could create some oases. And so we looked at, well, what's the knowledge translation challenge here, and how do we lean into this with an education series and the broader, you know, data dissemination opportunities around health pathways. And we ran a short sprint. And anyway, I was very excited the other day to hear that apparently there are some green spots emerging along that southwest coast. So it would be interesting in a learning health system to go back and say, have we actually made early medical abortion more accessible through some of our activities? And how can we say, you know, we were part of that change? So that was an interesting one around regional data and how you can use regional data to see change. We looked at persistent pelvic pain. This is a problem that isn't probably done well, but could be done well. It's probably one of those, I'd characterize this challenge as a high value, low value care. So we know a lot of people probably go into hospitals and have a lot of low value surgical procedures that perhaps could be prevented by good primary care. But we wanted to find out, well, what was the problem and why weren't GPs doing it, and what could really change that? And it was one of those interesting ones where, you know, when we specified this project at the beginning, I think a lot of people wanted to do things like build chronic disease management templates. But then when you actually spoke to the GPs about this, and we ran polls through our sessions and said, okay, well, would you think this person is eligible for a chronic disease management plan? And GPs agreed, yes, this clinical case was, you know, would necessitate that. Would you actually do it? No, well, I wouldn't do it. And then we'd ask, well, why? We found that there were a lot of systems barriers that now we're trying to lean into. So, so that's initiated, I guess, a new raft of project and research that we're kind of leaning into. And finally, ADHD shared care models. We were looking at, why don't GPs co-prescribe, and could GPs do some co-prescribing, because pediatrics are inundated and consumers really want their GPs to prescribe or even diagnose. That was an interesting series where we looked at trying to develop shared care models. And, you know, it could be interesting. You could probably even look at our EMR data and see if more prescriptions are taking place as a result of this series. But what we will probably do as part of our systems intervention is lean into secure messaging and think about communication channels between our paediatricians and our GPs to support shared care models. So look, there's a heap of information on the slides. Apologies that they're so busy, but you can tell there's probably quite a lot that comes out of these sprints, if you like. And I think that really what we've done is just the beginning. I think I'm at base camp. Is that right, Georgia? And I've got a summit, and this is my PhD with the IIHI. So I'd like to acknowledge my supervisors, Professor Jeffrey Braithwaite Dr. Louise Ellis and Dr. Georgia Fisher, who are going to help me summit this mountain. And we're going to look at a regional primary care-led learning health system, the development and evaluation using complexity-informed implementation science approach. I think I'm going to leave it at that, but it's going to look a bit like qualitative mixed methods research. Development of new models. But I think that's probably the best I can kind of do at this stage in terms of how I've scoped it up. But yeah, so hopefully I think the future's bright and we've come away from some of that turbulent times. Uncertainty is certainly going to be the way of the future, but I think with good complexity informed implementation science, we can be ready for it. So thanks.
Thank you. Wonderful. Thank you, Bianca. I'll open up the floor to any questions that anyone might have for Bianca.
I'm looking for my hand and I can't find it. Can I just jump in with an early one?
Oh yeah, I can put mine on. Yep.
Sorry, testing. Oh, that sounds much better. Except that now I think you're all mute and I won't be able to hear anyone respond, but I'll ask my question first. Thank you so much, Bianca. That was fascinating and an incredible amount of work. We've been running an ECHO, the Rarest project that Macquarie's been involved with as well. And so for most of your presentation, I was wondering, okay, what about when they're ingrained and sustained issues rather than, you know, emergency response issues, and you got to those. And so I was wondering about how you saw that engagement and motivation change when you moved to and did you maintain that same cadence of meetings across a sprint? And then I guess my second part to that question is, as you now move to very diverse areas across different sprints, you know, which could then overwhelm you with all the different issues and all the different types of data that you might need to collect to evaluate it. Are you sort of partnering with other projects, and do you see emerging sort of a model where that ECHO would then be a vehicle for other researchers to jump in on?
Okay, great. Thank you. Great questions. All right. So let me make sure I get this right. So cadence wise, we needed to slow it down. So we were running through COVID, say 8 to 10 sessions a term. I think about terms like school terms, if you like. And then we added in these design labs. So we formalized these design labs like huddles, if you like. And so we were trying to kind of then alternate like design labs and learning labs. And so we ran then fortnightlies, and that then meant we could run 5 a term, 5 ECHOs a term, 5 design labs a term, but that was still too much. And so now what we've got is we run 5 ECHOs a term, and I'm running them as weeklies. I think that short sprint suiting people. So someone said to me the other day, oh, when's sustainability ECHO starting? Oh, good, I've got April off, you know? So they are thinking they're quite liking these kind of intense sprints. And I think it keeps everything in your mind then. So it's better probably for systems change. And then the design labs, I'm thinking at the moment, they keep changing. That's the piece I'm really trying to refine. Who comes to them? What are the outputs of those? How are we going to make this useful? And so design labs probably depend what the problem that we're trying to solve. And how much energy is generated. Like ADHD could just have its own working group, to be honest. So I'm probably thinking about design labs now across a longer period of time. Like I think, you know, you probably need to start designing your sprint good 6 months out to do all your stakeholder engagement and do your consumer co-design. And, you know, there's quite a lot in that. And then you need to have those little conversations. Like I'm meeting up with my knowledge management team to talk about what they're doing, and the change management team, and, you know, just to kind of put things into practice. So, you know, it really could be anything. It just depends what your resources are. So that comes to the next part is, and in terms of engagement, I mean, look, we had probably in that antivirals webinar in 2022, we probably had 50 people, and I reckon I got better numbers in ADHD. So coming at 7:30 in the morning. So, but you've got to pick topics that they're interested in. So that's where it's really important that you don't, and I'm really trying to hold the fort and not be about the kind of state or federal policies. I'm really trying to make these issues that are real pain points on the ground. So you've really got to, again, do your teaching and learning surveys, ask them what they want to, one thing rolling on to the next is really good too. So you've just got to make sure they're really hot topics for primary care. And I'm a GP, so I guess I'm kind of, on the ground. But if you're not a GP, I guess you want to be on the ground and know what's hot for them. And so then in terms of kind of, so going forward, is this something? Yes. So like I guess going forward in my mind, when I first then made the transition, I was looking around to say, who's got a sprint that I could grab off the shelf and run? And of course, no one did. So no one had written me a 5-session echo curriculum or plan. And so I'm designing them fresh. And wouldn't it be great if someone else, like I'm about to do a CVD sprint. I'd love it if someone could hand me a CVD sprint that I could adapt locally. And so the idea being that I create a model that other PHNs or other organizations could we could partner with, like Echo is a real Echo's got that philosophy of democratizing knowledge. So every PowerPoint we build goes up into the iEcho cloud. Oh, you know that because you run Echo, right? So you can take any of my Echoes out of the iEcho portal, right? But in my mind though, that's data. We need to do the metadata. How do you run a sprint? So how to facilitate to facilitate, we share the logic of what we're trying to do, because this is not just Echo, right? This is systems Echo. There's a whole layer on top of this about actually trying to create systems change, not just education. So I think that's the challenge for me and for the AIHI team that are supporting me with my PhD is how do we actually think about the outputs so that it can be useful to other teams seeking to respond to similar problems.
Yeah, fantastic. I'll send you an email. I think we've probably got an off-the-shelf rare disease sprint ready for you.
Fantastic. Ooh, ooh.
Can I ask a question? Hi, I'm Shauna Gall. I'm an epidemiologist from the University of Tasmania and work in the field of cardiovascular disease. So I was very interested to hear you talking about the fact that you're interested in doing a sprint around that. And yeah, I love the proposed kind of method. And yeah, I guess I was wondering about, the resourcing for the program that you're kind of doing, because I guess it's quite labor intensive in terms of running those sprints and so on. And the other thing that I'm quite aware of in terms of working with GPs is the need to remunerate them for their time. So is this something that the GPs are engaged in as part of their kind of CPD, or how does that kind of work from getting them to participate in these activities which are not clinical care?
So, resourcing, we are using flexible PHN funding. So I sit with the workforce team and, like I think I'm interested as to how to really advocate for resourcing for someone like myself, whether it's in whatever discipline you are, but someone who can facilitate these types of systems level education / qualitative researcher. So I think about the role that potentially I'm playing is as an embedded researcher and as an educator. And so how do you get PHNs to see the value in that and resource that is the first thing. And then the coordination team. So my team, the workforce team, really are keen to orient a lot of their offerings around this type of learning because they can see it's very interactive and high value for clinicians. So anyone can, I guess, put out a didactic webinar that, nationally GPs could watch. But what we're doing is trying to solve local systems issues and bring local speakers. So that is a piece that I think they see the value in it. And also the last piece is that this is GP engagement, authentic engagement, and PHNs are getting a bit of a bad rap for that at the moment. And I think our crew are quite keen to see this as being a part of our engagement strategy and partnerships building strategy. So I think that, look, for me, I think through the experience of the pandemic and being in the trenches with this group, I think we've built a lot of trust, and I think they've been very supportive and sponsored at the high levels, they've sponsored me to turn this into a organizational model. And I can see that's going to be tricky for someone de novo to do, but I hope that through, this research of this PhD, we can prove that it's worthwhile investing in. That is a big challenge though. But I mean, I guess, and then what was the next piece? The next piece was related to GP engagement and what value do they see in it? Again, I'm keen to find that out in the PhD. I'll be looking at that. Can you sustainably engage GPs in this? I think that probably, you know, long term, the answer is going to be no. Like, there's not a lot of incentives for GPs to really do QI. I mean, they've got 50 hours of CPD. So we jumped onto that. It did change recently, and we jumped onto that, and we were the first to accredit a measuring outcomes activity for cervical cancer in Australia. So we broke ground on that one because we could see GPs had a need. But going forward now, I think there's about 17 other people who have kind of done that same thing. So how am I going to keep this audience with me? You know, that's a challenge. And I think I'm probably fortunate because, again, you know, we run over 130 learning conversations now, and I've got a trusted group. But different topics, different GPs come. So I've got a whole new crew that have come for ADHD, and I had a whole crew that came for women's health. And I'm sure for sustainability, I'll have another group again. So it's going to be interesting. I am probably relying on the transformation, but I mean, this sounds terrible, but the Medicare transformation is going to require a lot of conversations, right? And so I think as things kind of start to squeeze a little bit, I guess I'm going to be looking at how do we need to respond? And it's probably a bit early to say, but like, I guess that's where I go into something like CVD. I'm looking at that not only as a how can we improve cardiovascular disease, but how can we learn to create better data quality and ensure that, you know, we're ready for performance measurement that might be asked of us.
Right, we're at time. So feel free to, I think, email Bianca if you have any other questions. I'll say thank you for everyone. All right, I'm here verbally. Thanks everyone for coming to the Implementation Science Interest Group. Feel free to email Bianca if you have any further questions. Her email's in the chat. And we look forward to seeing you in a month's time at the next meeting. Thanks everyone.
Thanks so much.